Hello everyone, welcome back to our channel. Today we are discussing another crucial topic, hyperkalemia in cardiac arrest. This is a high-yield topic for the MRCEM exam and also an important clinical scenario you might face in the emergency department. Take a moment to review the question and options carefully and decide on the answer you think is best. We will go over the question, break down the answer choices, and explain why one option stands out shortly. Let's get started. Here is the case. A 79-year-old male patient is brought to the emergency department in cardiac arrest. During resuscitation, hyperkalemia is confirmed with a potassium level of 6.8 millimole per liter. The question asks, according to the European resuscitation guidelines, what is the most important initial management step to protect the heart in this patient? And the correct answer is option D, administer 10 ml of calcium chloride 10% intravenously by rapid bolus injection. Let's go through each option and see why calcium chloride is the top priority and why the other options aren't the best initial choice. Option A, administer 10 units of soluble insulin and 25 gram of glucose intravenously by rapid injection. Option A suggests giving 10 units of insulin with 25 grams of glucose. This is a common treatment for hyperkalemia because insulin helps drive potassium back into cells, lowering the serum potassium level. But here is the thing, while this treatment is effective, it takes time to work. In the context of cardiac arrest, we don't have time to wait for the insulin to take effect. Our priority is to protect the heart immediately, and that's where calcium comes in. This option is useful but should follow the initial step of stabilizing the cardiac membrane. Option B, give 50 millimole sodium bicarbonate intravenously by rapid injection. Option B is sodium bicarbonate. This treatment can be used to correct acidosis and shift potassium back into the cells. However, the evidence for its use, specifically in the hyperkalemia during cardiac arrest, is mixed. It's more effective in patients with severe acidosis or renal failure, but it doesn't work fast enough to immediately protect the heart from the effects of hyperkalemia. It's not the first line treatment to stabilize the myocardium, so it's not our initial choice. Option C, start a 10% dextrose infusion guided by blood glucose levels. Option C suggests starting a 10% glucose infusion. This is part of the insulin glucose therapy often used to lower potassium levels. However, like option A, this approach doesn't work immediately. The infusion is typically used to prevent hypoglycemia after insulin administration, but it's not going to stabilize the heart in the acute phase of a hyperkalemic cardiac arrest. We need something that acts faster, and glucose alone isn't enough. Option D, administer 10 ml of calcium chloride 10% IV by rapid bolus injection. Option D is the correct answer. Administer 10 ml of calcium chloride 10% intravenously by rapid bolus injection. Here is why. Calcium chloride works immediately to stabilize the cardiac membrane. Hyperkalemia raises the resting membrane potential of cardiac cells, making them more likely to depolarize inappropriately, which can lead to dangerous arrhythmias or even asystole. Calcium acts as a membrane stabilizer, reducing this risk and buying us time to implement other treatments to lower the potassium level. This is why it's the most important initial step in managing hypokalemic cardiac arrest. Option E. Consider dialysis for refractory hypokalemic cardiac arrest. Option is dialysis, which can be highly effective in reducing potassium levels, especially in patients with chronic kidney disease. However, dialysis is not a quick fix. It takes time to arrange and initiate. In the context of a hypokalemic cardiac arrest, we need an intervention that acts within seconds, not minutes or hours. Dialysis may be considered if the patient remains in cardiac arrest despite initial treatments, but it's not the first line action in this scenario. So the correct answer is D. Administer 10 ml of calcium chloride 10% intravenously by rapid bolus injection. This is the fastest way to protect the heart in hypokalemic cardiac arrest. Remember, calcium works to stabilize the myocardium immediately, giving us the precious time to implement other treatments like insulin glucose therapy or bicarbonate. Now a quick recap. Insulin and glucose, effective for lowering potassium but takes time to work. Sodium bicarbonate may help with acidosis but isn't the fastest option. Glucose infusion supports insulin therapy but doesn't act immediately. Calcium chloride, the fastest way to protect the heart, first line choice. Dialysis, considered for refractory cases but isn't an initial intervention. That's it for today's video. I hope this helped clear up the initial management of hypokalemia in cardiac arrest. If you find this video helpful, give it a thumbs up, subscribe for more MRCEM prep tips, and share it with your study groups. Let us know in the comments what topics you want us to cover next. Remember, you have got this. Keep studying, keep sharp, and I will see you in the next one.